Hello, this is Dr. Anjali Agarwal, consultant physiotherapist, lifestyle consultant, women's health specialist, and an advocacy co-director of Long COVID Physio and Telehealth Physio. Today, my topic for discussion is safe rehabilitation in long COVID. There's been a lot of talks and a lot of importance being given to the post-COVID sequel or the long haulers. And one of the important things to remember is that a lot of exercises are being pushed for these patients which are not safe for them. So what are the things which we can actually do for these patients? Myself, that's my introduction here. I practice out of Hyderabad, and at present in the COVID scenario, I've been helping a lot of patients on a telehealth medium. And through the telehealth medium, I've been able to address a lot of musculoskeletal disorders, pregnancy, postpartum, long COVID physio, and also representing EDS Society of UK in India. So deal with a lot of cases attached to EDS, POTS, and MCAS. Having graduated from SSKM Hospital, India, and both from UK, Edinburgh, I did a special training in heart manual facilitator training. I've been an advocate and a brand ambassador for Physical Literacy Days and a convener for well-being and health for CII IWIN Telangana 2018 to 2019 and 2017 to 2018. So let's dig deeper into the topic now. My message for all the physiotherapists, faculty, friends, and students is that we as physios play a very important role for the long COVID rehab. And the goals of my talk today is to compromise and kind of schedule something which is called as the safe and effective rehabilitation and recognize the complexity and viability of long COVID rehab. Now, the purpose of the talk is that physiotherapists should consider other factors important in symptom management beyond solely the physical activity. Now, the road of recovery is not a linear curve in case of long COVID. There'll be a topsy-turvy kind of ride, and we see that it's a bumpy ride and a bumpy journey. So not one patient will be the same as the previous patient one has seen. One has to keep faith and confidence and have a very thorough, determined focus in getting them help. Now, the rehab is post-sequel is person-centric, is patient-specific. So every patient is symptomatic, and those symptoms have to be addressed, have to be treated, and have to be looked after. Now, long COVID is supposed to be affecting the multi-system parts of the body, which includes your respiratory, cardiac, renal, and neurological and endocrine symptoms. Now, people having a cluster of overlapping symptoms such as fatigue, exhaustion, chest pressure, tightness, shortness of breath, headache, cognitive dysfunction. Now, long COVID can be multidimensional, spanning systems and impairments and active limitation and social participation and restriction. Long COVID can also be experienced as episodic, non-predictable in nature, and with symptom fluctuating and changing over time. Long COVID can impact the functional ability, the social, the family life, and the ability to work and quality of life for a simple person. Now, among the several symptoms which we see, long COVID has been presenting with several kinds of symptoms, which includes fatigue, shortness of breath, joint pain, cough, Sika syndrome, loss of smell, runny nose, red eyes, loss of taste, headache, sputum production, lack of appetite, sore throat, vertigo, muscle pain, and diarrhea. So we see among the big picture which we see in our patients is the fatigue. Many of them will not be fit enough to exercise for even 10 minutes, and they go very, very breathless with their heart rate just racing on, standing up. So all these little things which we have to keep in mind, and we will have to focus our rehab and getting the patient back on track, keeping these symptoms in mind. Now, exercise is a very debatable topic in COVID. People are being forced by several agencies that they need to go back to gymming and exercising and running. But unless we exercise caution for our long COVID haulers who might have a cardiac involvement and they might be desaturating, and we have to have a thorough checkup and analysis and assessment of these patients. And exercise safety and precaution and effectiveness has to be thought in mind. And then it's just not the children, the young people, that is everybody with long COVID will be getting affected. Now, the exercise and physical activity is beneficial, but we should make sure the goal of rule of thumb is do not do any harm when you are advocating any kind of exercise for your patients. Now, physical activity can be returning back to activities of daily living and using your skeletal muscle, and also there's an energy expenditure. Now, physical activity in life can be categorized into occupational sports, conditional sports, household activities. Physical activity should not be confused with exercise, which is a subcategory of physical activity. Exercise is defined as planned, structured, repetitive, and purposeful activity, focus on improvement and maintenance of physical activity. So we have to give a mini command to our patients as to this is what you got to be doing, this is what you got to be stopping at. Post-exertional symptom exacerbation is something, a very common phenomena we see in post-COVID scenarios. So monitor, assess, reassess, monitor is the word for them, and physical activity monitoring and response to physical activity monitor symptoms should be looked at in details. Cardiac impairment is one of the common symptoms as we see a lot of patients with endothelial dysfunction. The walls of the arteries are really getting affected. So in these scenarios, we have to look at what kind of exercise and sports they might be going into and doing it. The common phenomena which we seeing in the elephant in the room is called as the autonomic nervous system overdrive. A lot of times people with long COVID would have very much dysfunction of the autonomic nervous system, and this causes orthostatic intolerances in response to physical activity interventions. And SARS-CoV-2 with the autonomic dysfunction will present with autonomic dysfunction, breathlessness, palpitation, fatigue, chest pain, feeling faint or syncope, and could also cause exercise intolerances and a lot of issues with post-exertional breathlessness. Now, this is POTS, which is called as the postural orthostatic hypotension, which is a big elephant in the room. Now, the dysautonomia is an umbrella term which refers to the change in the autonomic nervous system that affects the health, which includes postural tachycardia, inappropriate sinus tachycardia, vasovagal syncope. Now, emergent evidences have come out that these are the common symptoms which are very much prevailing in all our long COVID patients. And the symptoms can present in change in heart rate and blood pressures whenever the person is upright. A classical way to ask your patients is, do you feel giddy on standing up from your sitting position? Now, what is the use of ANS? What does ANS do? Autonomic nervous system seems to control every aspect of your sympathetic systems of the body and the parasympathetic system. Now, sympathetic system is something which helps us to fight and flight. So we got to catch a flight and we are running short of time. We'll be running. And to go and catch the flight, what is responsible is the adrenaline drive. So that is our sympathetic system. And if a tiger is on the prowl and it's running after us, that's again the adrenaline going on a supercharged mode for us to help run and drive. But if we are on a constant phase of overdrive of sympathetic system, our heart rate and our blood pressure, our oxygen saturation all goes for a toss, and that can affect various parts of our parasympathetic system, which will not let us to relax, let us to breathe better, or let us to feel better, or let us to think better, or let us to sleep better. And also as a result of that, it causes in a lot of changes in the heart rate and the blood pressure and the endocrine systems of the body. The adrenal glands are super hyperactive, and that causes a real shift of hormones, which the adrenal glands are responsible for. So the autonomic nervous system is something which is being triggered very widely by this COVID virus, and is also causing something as ANS or autonomic dysfunction. Now, the regulatory system, as I mentioned, is the flight and flight syndrome. Whenever we do a strenuous exercise, it helps us to fight and overcome that barrier. But it helps us to also calm down, rest at night, digest our food. But if you're able to see a lot of patients complaining of constant diarrhea, constipation, heartburn, and feeling of not able to sleep at night, feeling like insomnia in the night. These are all because of the overdrive of the ANS. Without keeping in mind of the ANS, if we ask and push the person to exercise, his sympathetic system is again getting supercharged. Now, the screening of the POTS, how do you screen as physiotherapists or clinicians? We have to look at how the orthostatic hypotension or the heart rate differences are happening with the help of the NASA 10-minute test and the active stand test. The active test involves the blood pressure and the heart rate after 5 minutes of supine lying and then 3 minutes after standing. We measure these kind of graphic details. Now, orthostatic hypotension is defined as the fall of greater than 10 mm of mercury systolic and greater than 10 mm of mercury diastolic after standing for 3 minutes. Now, the head tilt about 60-degree angle, and the diastolic criteria for POTS includes sustained heart rate, which is greater than 30 beats per minute within the 10 minutes of standing, or the heart up tilt in the absence of orthostatic hypotension. The COMPASS 31 score is a questionnaire which can also identify the autonomic dysfunction. The range of the heart rate, the parameters, the variability, the recovery, the heart rate acceleration, all can help us assess the cardiovascular autonomic regulation. This is a common example of the test which we can do on a tilt table, which is done mainly in the hospital setting. But I've talked about the test which you can do with your patients on a telehealth medium by just looking at how their heart rate is varying or how the blood pressure is varying for them. Now, the orthostatic hypotension, if it is present, what are the things which as physios we should recommend is autonomic conditioning therapy and utilization of the non-upright exercises, use of isometric exercises, compression garments, patient education for safety, continued monitoring and assessment of post-exertional symptom exacerbation is definitely required, and also look at the rest and the quality of sleep, and always refer to a physio specialized physician for pharmacological treatments, and dietitian referrals are very important because POTS plays a very important role as to what the kind of food you eat, what time the food you eat, and the kind of pharmacological drugs in the form of beta blockers can be offered to them. Now, the patient report outcome measures, self-evaluation of breathing questionnaires, multidisciplinary dimensional fatigue index, default system questionnaire, and the post-COVID functional status. They're all supposed to be looked at for a patient. Now, as I've told you, that autonomic nervous system can also be helped with breath work and a very supine active range of motion of exercise. Upon achievement of sustained stability of symptom, that's when we introduce symptom titrators, submaximal aerobic exercises. So that's what I've told in plenty. With breathlessness, palpitation, feeling faint is the word for ANS. Consider non-upright exercises, isometric exercises, compression garments. Now, exercise-induced desaturation is a common phenomena seen in this long COVID rehab patients. We have to also understand there can be an endothelial dysfunction causing thrombolytic complications. Low oxygen saturations after exertion can be possible in the acute phase. But if it's the resting oxygen, degree of dyspnea, still feeling unwell, we really need to understand and get them back into our long COVID clinics. Now look at the factor here in the dysfunctional breathing. In general phase of breathing, our diaphragm should be up and down. But if this is not happening, it's actually causing an exertional desaturation, hyperventilation, breathing pattern disorder may be present. Hallmark increased respiratory rate, tidal volume during the exercises. Now, the underlying mechanism for hyperventilating in people with long COVID is not still understood. There could be an air trapped in the passage, or there could be less diffusion of oxygen in the capacity of the lung in the form of the carbon monoxide. So it causes a stiff diaphragm, your vagus nerve is not working, and then you also have the physiological or the biochemical reaction because of which you're not able to get your oxygen improved. So the word of advice is fatigue management, stop, rest, pace, respiratory, breathing regulation, cup management, autonomic response monitoring, watch for POT symptoms, exercise prescription when appropriate, and support and advocate for the red flags, which include increased heart rate going beyond a certain levels, and that can cause a problem. Now, this is the cycle of breath, which I always talk about, is the deep breath, the pursed lip breathing, and also the deep breathing, the pursed lip breathing, and the huffing and breathing. These kind of breaths has to be kept in mind and has to be done individually. So as I said, don't have high expectations. There can be a reality mismatch. Mind aims, unreal physical function. Now, expectation can be high, but it's not equivalent to getting back to normal in a short period. So do not expect that you return back to normalcy in a day. Now, this early intervention plans is to focus on concentric workout, look at the muscle, the cardiac deconditioning, but the word decondition is generally not used because it's a saga of stories which are happening. Also look at phase by phase development of the muscle. Early mobilization has to be looked at after the symptoms. Now we have to understand the physiology of this disease is that it is real. The impairment of the organs is real. Symptoms are true. Emotions are uncertain. Nobody understands what is going on. Clueless feeling. So life in general, it's a topsy-turvy road, and it's not a smooth departure from your acute COVID phase into your recovery phase. It is always a downhill and an uphill task to get your breath back, to get your fatigue managed. So little things that you have to look at. So return to exercise in a phased out manner, which is goal 1, goal 2, and goal 3, which is first return to monitor the clinical progress. How is the patient doing with heart rate? How is the patient doing with return to function? How is the patient doing to return to exercise? Now, that's my details, and which you can always connect with me one-to-one for your telehealth rehab on long COVID, because very few experts are knowledgeable about this condition. Very few do understand what's happening in the background picture, and a big role we as physios have to play. And thank you. On behalf of the long COVID physio, I thank everybody for listening to my lecture. This is Dr. Anjali, and you can reach out to me at 79816-3770 for your telehealth appointment for recovery from long COVID. Now, long COVID is an umbrella term for a lot of symptoms. The first symptom is not able to return back to doing activities or daily living in a comfortable manner. The moment you stand up, you feel giddy, you feel fatigued, and you also feel short of breath. You might feel a lot of heartburn, a lot of chest pain, a lot of sputum production, a lot of headaches, a lot of change in your menstrual cycles. So there's a saga of story which is happening in many of my patients, roughly about 40 patients if I kind of see in a day from long COVID phase. I think it's a very sad story which I see, but I think there's light at the end of the tunnel. Slow paced, but we'll get there. Thank you, and welcome to my telehealth appointment systems, and reach out to me for any kind of queries. Thank you. Bye-bye.